Welcome everyone to the Interprofessional Collaboration panel with our regional experts and our local response to all of the sessions that you've been hearing about this week as part of the Karen McNeely Heard series. We are so grateful that you've decided to join us today and our expert list of panelists. And we hope that this is a beneficial conversation that helps summarize and bring home some of the messages that you hopefully heard about this week. I am Lynn O'Connell, and I'm the Associate Director of Addiction Sciences for Marshall Health and the Joan School of Medicine, and also the Chair of Healthy Connections. And so this has been a wonderful week involving a lot of different speakers from around the country, and I would be remiss if I did not acknowledge all of the amazing work that has gone into this by Quality Insights and their wonderful team, along with the Communication Disorders Department on campus and Marshall Health. And so all of those groups working together to make this possible. So like I said, thank you so much for joining us. You will notice on the side of your screen is both a chat and a Q&A function. Please utilize the chat to discuss what we're talking about and your remarks or thoughts on things, both that we're sharing during this panel, but also for the things that you might have taken away during the week from the topics that you learned about. Please use the Q&A to offer up questions to our panelists, whether they be about what we're talking about or about the sessions that you joined in this week. And that just allows us to streamline the Q&A process and not lose that in the chat. So thank you for doing that. All right. So first off, I want to share our different presenters, and they're going to introduce themselves. But we have Dr. Zach Hansen, and he works with Marshall Health. We have Dr. Mills Price, also works with Marshall Health through the MARC program. We're grateful for the participation also of Rachel Thaxton from the West Virginia Office of Drug Control Policy, and Tina Ramirez from Marshall Health and the Great Rivers Regional System for Addiction Care. We think that we know that our panel are experts across the areas of addiction and recovery, and we're really excited that they were able to join us. At this time, they have no disclosures to report. Our goal today of the panel is just to talk a little bit about addiction and recovery and how we can learn from the conversations that we had this week from our experts and bring those messages home. Also learning and sharing a little bit about local resources that tie those messages from the larger community to our local community. And having the opportunity to discuss some of the questions and answers that came up throughout the week. So I'm going to hand it over to Dr. Zach Hansen.
All right. Can y'all see the slides or no? Oh, hold on. I'm working. All right. Are you seeing them now?
Yes, Zach, we can see them if you there. Yep, make them big. Perfect.
All right. Uh-oh, they're on a timer now. All right. So I'm Dr. Zach Hansen, newly sort of hired into this position as Medical Director of the Division of Addiction Sciences through Marshall Health. So there are obviously a lot of different things going on within the Division of Addiction Sciences. So I'm just going to sort of talk about sort of the one that I'm most involved with and have the most sort of knowledge with, and that would be PROACT. So PROACT is a collaborative effort between Marshall Health, St. Mary's, Cabell Huntington Hospital, Valley Health, and Thomas Health. And it was sort of born out of an idea that we had a lot of different silos in the community as far as treating patients with MAT, but each entity was not really large enough to generate enough revenue to pay for services that were not necessarily reimbursable. And so by collaborating, we should hope would be able to be large enough to start provide some of those ancillary services. We also wanted to take advantage of the fact that each entity sort of had strengths and weaknesses to some extent that we needed to overcome to provide the best quality product for the community. So you can sort of see our goals: bridge services between hospitals and outpatient care, provide rapid response admissions for referrals. We currently have open access, and so anyone can walk in Monday through Friday, 8 to 5, get an assessment, and if they're appropriate for MAT, can be started on MAT services, or if they're appropriate for outpatient or need a referral to another level of care, then we can make that referral as well. We wanted to hopefully expand treatment capacity for our service area. A lot of programs for many years had waiting lists, and it was very difficult to get in to be seen. And so we wanted to have more capacity. And then hopefully in the long term, as the program grows and gets larger, then we'll be able to look at some research and sort of look at best practices and determine what we're doing that's working and what is not, and then be able to share that with the community, addiction treatment community at large. You can sort of see the different aspects of services that we offer through PROACT. So MAT or prescribing is only one portion of the program. So each patient is expected to do individual therapy, typically 2 30-minute sessions per month. They have group therapy, which is an hour every week. We have case management services that help sort of look at the social determinants and barriers to care and sort of overcome those. We have spiritual care through collaboration with St. Mary's Hospital. We have 3 recovery coaches that are part of the treatment team to help assist patients overcome various barriers or areas of need. We have some worksite monitoring and working with local employers so that we can monitor their workforce. We have a grant through CORE, or Creating Opportunity Recovery Employment, for career placement, and to place, I believe, over 100 individuals back into the workforce since its inception. And then, as mentioned before, sort of referral out to different levels of care if that is what's in the best interest of the patient. So sort of what do we offer here on site? Medication-assisted treatment, either buprenorphine or naltrexone, abstinence-based therapy. Not everybody needs to be on medication. We can refer out for higher levels of care, whether that be intensive outpatient, detox, residential, etc. We're looking at social determinants of health and trying to address those, and then also do referrals for medical care to ensure that everyone has a primary care physician. Get psychiatric support, infectious disease. We see a lot of hepatitis C particularly, and then GI again for hepatitis C treatment once they've met those criteria. But that's sort of everything or what we're doing here at PROACT in a nutshell.
Thank
All right.
you.
I need to. Did I stop already sharing?
I think so.
Okay.
Tina?
Okay, can you see it on your screen?
If you click the From Beginning button all the way, there you go.
All right. All right. So I am Tina Ramirez, and I'm the director for Great Rivers Regional System for Addiction Care. And pretty much when we talk about Great Rivers, it is a collaboration between a lot of different partners. We have 6 different legs of the project, and we are funded by the Merck Foundation through Marshall Health. So you can see the 6 different legs here. One of them is community health, education, and prevention. We also have harm reduction strategies. And that is through the different counties that we'll talk about that we're in. But the health departments are usually the ones heading up these harm reduction strategies, as well as hospitals and primary care locations. So a lot of people know about the harm reduction, and it's not just about syringe service programs. So that's what comes to mind a lot of times when you talk about harm reduction strategies, but it's way more inclusive than just syringe service programs. We also work with the quick response teams, which, if you're not familiar with quick response teams, they are a group of individuals from EMS, law enforcement, faith-based, peer recovery that go out and respond to individuals who have experienced an overdose. Those teams go out between 48 and 72 hours to the location where the overdose has occurred in hopes of connecting with the person who has overdosed. A bonus for this team is when they also meet with family members at that location or other people who are, suffering from SUD, and it's to help link them to services in the community. If you've ever talked to any member of a quick response team, you will quickly find out that they get as much out of it as the clients that they serve. So in the past, we had heard a lot about, burnout and first, responders having to go to the same location multiple times and not really having anything to offer, to the individuals that have overdosed. And this is a way to link them into the community and let them know that we truly care about everything that's going on in hopes of, them becoming productive members of society again. Project Engage is another leg of the grant that we work with, and this is with hospital settings. So in the hospitals that have the Project Engage program, no matter where you go into the hospital setting, whether that's emergency department, to have a baby, or to even just have general services, you're screened and ask a couple of questions. Do you have a substance use disorder? And without that substance, did you go into withdrawal? So this is a great opportunity for the hospitals to address the issue of substance use disorder from the very beginning. That way we don't have people who are leaving against medical advice, and you're bringing peer recovery support specialists to bedside and really have a whole team embracing the patients as they come in. And as Dr. Hansen talked about through PROACT, another focus is expanding pathways to treatment and recovery. So PROACT is a way to get everyone in one location, a one-stop shop, and meet their needs depending on what they desire. And then the last leg that we work with are the naloxone education and distribution. So naloxone is provided in all the counties that we're in, and we go and do community events. We work with quick response teams. We work with hospitals, everyone, just to make sure that naloxone, which is going to help reverse an overdose, is getting into the hands of people that need it most. Oh, so sorry. So sorry, it skipped my last screen.
Yeah, it's kind of cutting off your slides, Tina. Can you expand to full screen?
Good question.
Just maximize that window, maybe.
Yeah, is that better?
There you go, and then do from current slide.
Okay. So really, Great Rivers, a lot of what we were seeing in the past was, I'm doing a program right down the street, Lynn's doing a program, and no one's really communicating, what they're doing. So the idea is a systems integration to make sure that we serve 4 counties, but we also do a lot statewide with other groups. So Jackson, Kanawha, Putnam, and Cabell counties are the ones that we're initially working with under Great Rivers. And just to make sure that, we have coordinated efforts, and the counties have been awesome to be able to share the data that they have, to share the materials that they have. So if one of the bigger counties, has something great, the smaller counties can get that as well. So this has never been done by the Merck Foundation or anyone that we know of currently. So it's a one-of-a-kind concept to just help get out there and reduce the number of overdoses and overdose deaths, to really talk about access to treatment and reduce the spread of infections. So you can see on the bottom there my contact information and our website. If you have any questions during or after, you can get a hold of me. Thank you.
Great. Thank you, Tina. Dr. Price?
All right, can everyone see that?
Yep, looks good.
All right, so my name is Dr. Jennifer Mills Price. I'm a clinical and forensic psychologist. I was trained and practiced in the state of West Virginia. My home base at Marshall Health is in the Department of Psychiatry and Behavioral Medicine. And Healthy Connections is actually what lured me away from a really comfy job in a private forensic practice. I used to work for Hudson Forensic Psychology. And I continue to do work around issues of substance abuse, trauma, and child welfare. And in addition, I'm currently the program director, clinical supervisor, and a therapist for the MARC program, which stands for the Maternal Addiction Recovery Center in Marshall OBGYN. The structure of the MARC program, it is a MAT program, meaning medication-assisted treatment. We use predominantly buprenorphine product, but we also, if there is a mom who can be safely transitioned to Vivitrol or who's already on Vivitrol when she enters the program, we will allow her to continue that. We follow state office-based MAT guidelines and Medicaid guidelines. They tend to be the most stringent, so that helps us keep in compliance with everyone else as well. We require our patients to attend weekly group therapy for 1 hour and at least monthly individual therapy. That's the minimum requirement. However, we often catch moms on the fly. They need to talk quickly before or after group, or a phone call or telehealth call in between. So they're normally getting a lot more contact than that. We have urine drug screens every week, a blood draw each month. We
Uh-oh. I think we might have lost Dr. Price for a moment.
pregnancy and supporting their recovery. In addition to the MAT program requirements, we also require that patients attend all of their OB appointments. Their prescriber for the program is maternal fetal medicine specialist. We have Dr. Chafin and Dr. Cottrell with us, and they receive their med management visits at their regular OB appointments. So those become more frequent as they get toward the end of their pregnancy. Our patient characteristics, we see pregnant women up until 6-week postpartum when they check out with us and are no longer considered an obstetrics patient with primary opioid use disorder. We also see women with other substance use disorders and mental health conditions, but because we are a MAT program, we are focused on opioid use disorder. Our patients are predominantly Caucasian, low income, and heterosexual in a relationship but unmarried. Most have a history of treatment, but are not in treatment at the time their pregnancy is discovered. Even setting aside some of the psychosocial stressors that our patients face, around 50% of pregnancies in the US are unplanned. And therefore, we have a lot of women who were not necessarily intending to enter recovery when they discover they are pregnant. Most of our patients are not first-time mothers, and many have actually lost custody of other children, which is an issue that can create trauma for our moms. And a substantial minority, so not most of our moms, but a pretty substantial portion of our patients have been through this process before. They've had other children who had a neonatal abstinence syndrome, either because of illicit drug use or from being in a similar program during a previous pregnancy. Our goals, our primary goal is to maintain a healthy pregnancy with minimal complications. We encourage that by reducing polysubstance use. We don't allow patients to use other substances such as marijuana, methamphetamine, etc. And we shape those behaviors sometimes by shortening the window for folks to get their prescription. They may have to come in, check in every 2 days. They may have to increase therapy in order to shape that behavior. We encourage routine prenatal care. Again, using contingencies such as shortened scripts if necessary. We identify other factors that can affect the pregnancy, such as malnutrition, domestic violence, and homelessness. And we also monitor and treat postpartum depression pretty aggressively. Depression is highly comorbid with our patient population. Our secondary goal is to increase motivation for change. Remember, many of our patients were not intending to get sober when they discovered they were pregnant. We utilize, during our group therapy time, some consciousness raising activities. For example, we may have folks from the neonatal therapeutic unit come in and talk about neonatal abstinence syndrome. We often will have, during normal non-pandemic times, a speaker from branches come in and talk about the cycle of domestic violence, just to give people information and open their awareness to some of the issues they may be going through. We also work on stigma reduction, including self-stigma and how to address nosy questions you may get from family members. We encourage sharing by members who are getting ready to graduate and move on to their aftercare program. And we also connect patients with peer recovery coaches. Something that has been a really wonderful development that has happened during my time with Mark is that we have peer recovery coaches working under the Healthy Connections umbrella who are actually able to come sit in on groups and be there for those on-the-fly moments, because that's really what helps our patients to develop trust in the peer recovery coach and utilize those services, which are so important. We also, as a tertiary goal, kind of start where other therapies normally start. We like to help our patients to meet their goals and improve their adult social role functioning. So we assess, treat, and potentially refer if it's something that requires more intensive treatment for comorbid mental health conditions such as depression, bipolar disorder, and PTSD. We assist patients in identifying needs for vocational services such as CORE, parenting, adult life skills. We don't provide those in-house, but we do refer those to programs that are under the Healthy Connections umbrella and or things that may be closer to home for some of our moms coming in from more rural counties. We have child protective services. We have a supervisor, in child protective services who presents in groups to answer questions that patients may have and to help them start thinking of ideas for their in-home safety plans should they require one. Our different community partners present in group, and our primary therapeutic model that we use in group are dialectical behavior therapy, or DBT, SUD informed coping skills. So we focus a lot on handling difficult emotions, getting through acute distress, crisis, improving relationships, and developing mindfulness skills.
Great. Thank you so much, Dr. Price. Rachel, well, how about you talk a little bit about who you are and what you do with the Office of Drug Control Policy, and we'll go from there.
Sure, I can definitely talk without slides. So I'm Rachel Thaxton. I am the Assistant Director for the West Virginia Office of Drug Control Policy. I'm also a person in long-term recovery from a substance use disorder. So for me, that means I haven't put a substance in my body since July 24th, 2013. So I wanted to show you all this slide of kind of the progression of the drug epidemic in West Virginia in terms of overdoses from 2001 to 2019, which was the first slide. I wanted to show you that to say this, that basically the drug epidemic in West Virginia, oh, there it is. Thank you, Lynn.
No problem.
The drug epidemic in West Virginia, you know, is a health crisis. It's a social service crisis. It's an economic crisis, and it's an ever-evolving crisis. And West Virginia has really been ground zero for a convergence of many of today's social, emotional, and socioeconomic challenges, which has made us fertile ground to be the epicenter of this drug epidemic. And as you can see in the graph, is that in 2017, West Virginia really reached a peak. And that's when we saw the creation of the Office of Drug Control Policy. You'll go to the next slide there, Lynn. The Office of Drug Control Policy was formed in 2017 by House Bill 2620. We are housed within the West Virginia Department of Health and Human Resources, and are tasked with coordinating the statewide efforts surrounding prevention, early intervention, overdose reversal, treatment, and recovery supports. And in addition to that, we're also tasked with leading the statewide response and developing the strategic plan, statewide plan to reduce the prevalence of substance use disorders, and smoking is also charged to our office as well. And you can go to the next slide. So the Office of Drug Control Policy, in collaboration with the Governor's Council on Substance Abuse Prevention and Treatment, developed and published a 3-year plan that started at the beginning of this year. So it goes from 2020 through 2022. So we've been working on this all year. It's a framework for state and communities that centers around 7 different focus areas. And those focus areas are prevention, community engagement and supports, which includes things like employment, transportation, and housing. And then we have health systems, treatment, recovery, and research, court systems and justice-involved populations, law enforcement, and then another focus area devoted solely to public education around stigma. So these 7 focus areas all have a corresponding subcommittee on the Governor's Council. And we've recently just formed a brand new subcommittee for the Governor's Council, and it's a committee of people in recovery who have lived experience. And that committee was just formed at the direction of the Implementation Committee for the Governor's Council. And we think that this is just a wonderful opportunity for the Council and the Office of Drug Control Policy to get feedback from people who are directly affected by this framework. You can go to the next slide, Lynn. Again, I wanted to just touch on a few of the initiatives that the Office of Drug Control Policy has either innovated due to the statewide strategic plan, or in response to COVID-19, and just to overall see the reduction of overdoses in West Virginia. And I don't have to go through all of these because some of the partners on this webinar have already touched on some of these initiatives, and we partner with many, many organizations. And the first one are quick response teams, which Tina talked about, how quick response teams operate in West Virginia. And they have been expanded across West Virginia and will continue to be expanded even more in 2021. We see these quick response teams first being formed in the counties that we know have the highest rates of overdose. And from there, we're trying to cover as many counties as we can in West Virginia. And it's such an important service in the early intervention and linkage of people to care. Naloxone is a life-saving overdose reversal drug, which Tina also touched on a little bit. So Naloxone distribution has increased with changes that were shepherded by the Office of Drug Control Policy and the University of Charleston and many other groups. Changes to Senate Bill 102 that relaxed guidelines on who can dispense naloxone around the state. Atlas allows users to go onto a website and compare treatment facilities side by side, or filter them by selected criteria such as location, program needs, insurance carrier. It really allows patients and loved ones the ability to leave feedback on treatment facilities and look at the qualities that in treatment that they might want for a loved one. The Chest Health app, which is called Connections, was put in place to help support individuals in recovery. West Virginia partnered with Chest Health to launch the Connections smartphone app. And it's scientifically proven to support individuals in recovery by reducing relapse and promoting pro-social engagement. So you can access that app for free. And in the resources section of this slideshow, our website is listed there. So that's where you can kind of find all this information. The Treatment and Recovery Resource Map, which is up on our website as well, allows people to search for resources in West Virginia by type of program, by gender served, by location, by the ASAM level, and it includes all the crisis centers, intensive outpatients, residential treatment programs, medication-assisted treatment programs, drug-free moms and babies programs, and the federally qualified health centers in West Virginia. So that's a great resource for people who are looking for treatment options. We've done lots of trainings in West Virginia over the years, as this has been an evolving crisis, like I talked about a little bit before. But one of the ones I wanted to highlight today was a training done by the Hazelton Betty Ford Foundation, who's come to West Virginia to teach us about the comprehensive opioid response with the 12 steps model. This model is treatment that is centered around embracing multiple pathways to recovery, which we know is so important. And then some other initiatives that I won't go into too much detail about because I know we're short on time and I don't want to take up the whole time. But START is an initiative to keep families together, so to keep mothers with their children and families united as they go through the recovery process. It involves CPS, collegiate recovery programs, which we heard about this week, which I thought was really great, but our office funds several of those programs around the state and on many campuses. Diversionary programs like law enforcement assisted diversion and family treatment courts, which really build on the adult drug courts that we've seen all over the state. And then the Governor's Initiative Jobs and Hope West Virginia, which addresses barriers that people have to employment in West Virginia. And I think that is my last slide. I just want to say thank you all for having me today. I'm excited to be here. I'll turn it back over to Lynn.
Great. Well, thank you all. Thank you all for sharing. I'm getting feedback on me. So I just want to ask each of you to briefly, like minute or less kind of thing, summarize something from one of the speakers or one of the topics this week that you took away as meaningful or impactful or something relevant to your work. And since Rachel, you were just on, can I start with you? If you didn't freeze. If you did freeze. You did freeze.
I'm trying to, I'm having technology issues.
I can now.
You hear me? Okay, good. I'm sorry, I'm ruining it for everyone now. So yes, I would love to comment. I really enjoyed all the sessions, and as I listened to the sessions throughout the week, I was impressed by obviously the phenomenal speakers that were gathered for the event, and then they were addressing a number of difficult issues, including the target populations like PPW, adolescents, and the LGBTQ, and things I didn't even know about the IA+. And as a person in long-term recovery who gets to do work in the field of treatment and recovery, I always find it interesting to hear about new solutions to experiences that I've lived through. I have lived through the experience of being an adolescent with an SUD, and as a woman who has been pregnant in early recovery and really leaned on the experts that were in my life at that time to help me get through that process and also maintain my recovery. Also worked in the collegiate recovery arena in my role with the ODCP. So it was really hard to narrow down a session to highlight. And really two things that I noticed while listening to the sessions is one, stigma plays a role in the treatment of SUD in a really negative way, unfortunately, and it has to be addressed if we're going to continue to make progress as we battle the drug epidemic in West Virginia and across the nation. And that seemed to be a recurring theme in all the sessions. And another theme for me that I noticed was the shift to the person-centered care and individualized care. It was refreshing and encouraging to hear all the different presenters touch on this approach, respective to each of their topics and their focus populations. One session that stood out for me was Dr. Martin's the opioid and substance use disorders in women through the life course. Again, I was pregnant in very early recovery, so that one really hit home for me. Dr. Martin made it clear that, addiction is a chronic disease that extends into pregnancy, just like diabetes or hypertension does. And when people continue to use in pregnancy, that is a very strong indicator that they have a substance use disorder, and we need to increase support and engage women in services more than ever. So she also said, evidence-based treatments for substance use disorder are obviously effective and should be tailored to individual needs, which again, I think is just so important. And I know, pregnant mothers lean on their healthcare professionals, and it's a scary time in the best of circumstances, but absolutely terrifying, if a mother is still using and wants to stop but can't, and also somebody who's newly in recovery, thinking about going through the labor and delivery process without pain medications can be scary. So really just engaging them and giving them the support that they need, and the positivity, and the belief that, it is possible. People have done it before, and connecting them in that way. So I really enjoyed that session, and I hope I didn't ramble too much, but all of them were very useful, and I thought all made very good points.
Thank you, Rachel. No, I think those were key takeaways, especially from that discussion, and she highlighted that in such a clear way. So, Dr. Hansen, can I pass it to you? Don't look surprised, you're on a panel. You're on mute too if you're... Zach, I think you're on mute.
I have to be honest. I tell my patients to be honest. The week has been too crazy, and I wasn't able to see or listen to any of the presentations, so I can't comment because I didn't see them, unfortunately.
You're all good. Tina, what were some of your key takeaways?
Yeah, so I think one of the things that really resonated with me is all the great things we are doing in West Virginia. So from the kids to the pregnant mothers to mindfulness. So I think that a lot of times we're like, oh my gosh, we need to do more. So what I really enjoyed about all of it is finding new presenters that we haven't heard before in some cases, and being able to rely on them as national experts. And I think if anything good has really come out of COVID is that we have access to these experts now. And they can come in and, we have speaking engagements that we can, get them involved in and everything. And one of the things that I know that, my group likes to do is this gentle yoga that ties right into the mindfulness. So we're hoping to expand that. We do it, Jessica does it Wednesdays at 10 o'clock during our Facebook page, but we really want to get in and provide an alternative to people who are really struggling and trying to find a way to manage the different things that are going on in their lives. So, but I do think that we all need a round of applause for all of our substance abuse prevention coalitions throughout the entire state. They have remained super active, even with the children and all the things, obstacles getting into the schools. So I think we're doing a lot of great things, and this is just another way to expand on all those efforts that we're doing already.
Absolutely. Thank you, Tina. And Dr. Price.
Yeah, so building on both what both Rachel and Tina were saying, the presentation that stood out to me, and I am biased, but it was Dr. Mariala's presentation. So for anyone who didn't catch that, she discussed the neural pathways that are involved both with addiction and with parenting and early attachment, and how the reward system can get hijacked, particularly with the use of opioids, and how that can interfere with some of the cascade of responses that unfold during and after pregnancy. This is definitely something that we talk about in group all the time. So patients who are doing well and who are stable say, it was not like this with my oldest child when I was in active addiction, and people don't really know how to deal with that. They need a lot of support through that. One of the things that I would love to see more emphasis on is, being having been a mom myself and going through, actually prepared for natural birth, failed, but prepared for one. And we talked a lot about behavioral methods of increasing oxytocin and bonding. And if you are, because if you have depression, you also have difficulty with that natural cascade of hormones. And I would love to see us utilize behavioral methods of improving attachment for folks that it may not physically come as easy because of their condition.
Excellent. Very good. Thank you, Dr. Price. So one of the questions that came in this week was around Dr. Fishman had spoken about adolescents and substance use in adolescents population. And I think for me, this was one of the talks that did stand out. He really shared the idea that there has been some good headway in prevention messaging, and clearly something is working in regards to some messaging, in that alcohol and tobacco use in when they sampled 12th graders and below is actually been on the decline. But when you talk to adolescents, they often report, well, everybody's using. It's sort of just like everybody's drinking, everybody's binge drinking, everybody's using tobacco. And so he talked a lot about normalizing that conversation, and that primary care really needs to just be having that conversation with everyone. And also, obviously, he supported motivational interviewing, which is always, I don't know many people who don't endorse it, but it's always good to hear another endorsement of that, especially with adolescents. But he also then brought up the program that they have in Maryland around medication-assisted treatment with adolescents. And so one of the questions that had come up in the discussion was, he had stated, obviously a lot of information, but had stated that medication-assisted treatment should be used, quote unquote, as first line with adolescents with OUD treatment. And so I wanted to ask Dr. Hansen a little bit about treatment of adolescents, as I know it layers on stigma and fear and lack of information and education around medication-assisted treatment into another vulnerable population. And so what maybe are some of his thoughts or medical knowledge on that?
Yes, yeah, it's a very interesting statement, and it's also a very interesting sort of question, in that, if I think of my own sort of personal beliefs and feelings, if someone comes in who's relatively young and maybe hasn't been in active substance use for an extended period of time, you don't necessarily want to put them on medication for fear that they may stay on medication for a prolonged period of time. And so we have this sort of, or at least I know, and I'm going to assume that he does, a lot of people do, that just don't want to start down that road thinking they may get stuck on that road. But you're forgetting the fact that withdrawal and the inability to physically withstand the withdrawal syndrome is one of the primary reasons why individuals continue in their substance use disorder. They have the desire to quit, but they don't have the strength or the ability to sort of get through that physical sickness. And so to say that we're going to send them to group therapy or individual therapy or do meetings or whatever it may be, and not to address the physical component of the illness is putting a barrier in front of them that can be hard for them to overcome. And so I think he's saying that, you know, we have a way to make it to where they're not sick. We shouldn't be afraid to use it. And we should just try to be very proactive in our therapy and in our treatment plan to make sure that we move towards weaning them off and not allowing them to go down a path of long-term MAT treatment unless it becomes clear in their treatment that is the appropriate course. But I think there's a fear, I know there is for me, putting someone on medicine that we're not able to get them off of, and so that's what there's a reluctance to start it.
Okay, it's a really good point, and I think it is an important consideration. I think a lot of what he discussed was, you know, if you have an adolescent with severe opioid use, you know, and we're choosing to try a ton of interventions, and all of those could lead to death. Do we have the obligation to intervene in what we know works, and we can have? So I think it's definitely a program to look into. Maryland's pilot interventions with adolescents and their use of the ACT teams that go out in the community. We have those, you know, those have been nationwide, but they're tailoring that and piloting that with adolescents with OUD. So it was a very interesting discussion. And also there was another talk focused just entirely on adolescents as well. I'm stuttering over his last name, Buskin, but he did a great talk on intervention specifically around adolescents. And so I think it's an area that it's probably the one area that I think we struggle with on our continuum. Obviously, there's always areas for improvement across all of our platforms and interventions, but understanding that adolescents develop substance use disorders, as we heard many times throughout the discussion. And we know that that's what our prevention coalitions are trying to address and what our PRIDE surveys indicate is happening. And so having interventions is going to be key for that group. So I wanted to also highlight Kalpana's talk and Dr. Danielle Nadorf and her graduate student talked about parenting and kinship care and the role that both of those play in substance use disorder and the world of substance use disorder. And so it made me think a little bit about how much of our interventions and treatment modalities are focused around a target population. And that often leaves out everybody who is not the target population. And Dr. Price, you brought this up a little bit. And so I wanted to hear what some of your thoughts were on how we can incorporate treatment and recovery and messaging to entire family systems and not just what we consider our quintessential maybe 2.5, family style, 2 parents and the 2.5 children. And so how we need to branch out from that in treatment.
Sure. So my background with substance use disorder treatment has been primarily in gender-sensitive programs since about 2008. So Renaissance through Prestera, that was one of my practicum experiences when I was in training. And it's incredibly important and still incredibly important. And I think I still want to emphasize that we are missing, some of that target population that still needs help and is either afraid or not prepared, or we're not reaching them somehow. I do still want to emphasize that. At the same time, what I'm noticing both on the treatment provider end and in the child welfare end is that more than I have seen, so that's in a 12-year period, more than I've ever seen before. We have a lot of young single fathers who are going to be raising children who may have either attachment issues or in some other way they were affected or maybe even, behaviorally impacted by parental substance use, whether it was their own or the child's mother. And a lot of gender sensitive programs for many years have emphasized parenting skills, attachment, bonding, and kind of family systems issues. But men's only programs historically have not. I've heard bit by bit, there are some of our, particularly the peer run programs in the greater Huntington area. Some of them do talk about parenting and provide a lot of additional support for dads who may be getting supervised visits while they're in treatment, things like that. But that is a huge gap that I see, especially when I think about my patient population. If you have two parents in recovery and a new infant, by being able to address the needs of both, you double the chance that there's going to be somebody who is there if the other one stumbles. So that's a piece of our population I really have seen kind of missing out. And I'd like to see more young men get more information that is family oriented and parenting oriented.
Great. No, absolutely. So I wanted to highlight something that came up quite a few times in many of the different talks. But Tom from VCU and Collegiate Recovery, I love that he gave a shout out to Susie Mullins and the work that's going on in West Virginia. So if you don't know about Collegiate Recovery in West Virginia, you are not talking to Susie Mullins, and you should be. So let us know if you need to get in contact with her and that great program. Because I think, again, when we look at this continuum, I've often described it as whack-a-mole, right? So you realize that you need treatment and recovery. So you set up that, and you need long-term residential, and you need, safe and supportive housing, and you need all pathways to recovery. You need all these different things. And then you start down your target populations, your single moms, your single dads, your foster care families, your kinship care, your formal and informal kinship care. I learned a lot about kinship care this weekend. I think we all need to take a focus on that. But then you start looking at different systems in your education system. So you need prevention, but then you need the college piece and the trade school, all those, right? So the minute we think we've tackled one, there's many others. And so Tom and many others spoke about the role of these other components of treatment and recovery is not just, the opposite of addiction is not just sobriety and not using substances, but rather connection, hope, and having an active sort of life. And also he mentioned service. And so, Rachel, I want to just briefly ask you, when it comes to building upon and finding purpose, how can we activate different organizations and groups or people to give someone purpose on their pathway to recovery?
Hopefully I'm unmuted. Yes, I think I am. Okay. Well, thanks, Lynn. Yeah, so Collegiate Recovery is a great jumping off point. I think it's sometimes a population where we kind of miss the mark because colleges and universities and higher education play such an important role in furthering our recovery in a positive way. So we obviously need to have gainful employment. And one pathway to that being successful is obviously going to college and being on a campus. And sometimes those can be really risky environments. And so that's a good jumping off point. And it's been, a pleasure to work on that project. But outside of that, there are so many groups that are already working on this and doing such great work. There's loved ones, there's teacher groups, there's all kinds of different employee-based groups. But I think that, in our work, we're trying to engage as many different populations as possible. And one way we're doing that is with CORE and with Jobs and Hope is really focusing on employee-friendly, recovery-friendly employers, I should say. And when we do that, we're really kind of touching on many different populations all at the same time. So we're looking at food service employees and people who are just entering the workforce, and call centers, and construction workers, and doctors and nurses. And it really kind of gives everyone a chance to feel safe and included and connected to other people who are just like them, no matter what their profession. And so that's one way I think that we're trying to reach people, on the other side of higher education. And also, there's a lot of great work being done in schools to make people feel connected, SAD chapters and prevention and things like that. I wish we could do some more work with, again, and we know we need it, and it's been talked about quite a bit this entire week, with adolescents, this idea of recovery high schools and things like that is just so cool. We're not quite there yet, but, I've talked to some people from Ohio who have done this recovery high school, and it's just the coolest thing. And we have some more opportunities to make people feel connected in West Virginia for sure.
Hi, Lynn. I think you're muted.
I am. I did the whole thing. I think that's the first time I've had to be told I'm wrong. Anyway, Tina, I wanted to ask you a question in closing. When you think of all the different groups that need to come to the table, we heard a lot about, the topics and presenters this week really shared, across so many different platforms. They were from so many different states. They came from many different perspectives and organizations. But, the message is clear about, we need to offer pathways to recovery, that substance use is a chronic relapsing brain disease, that treatment and recovery matter, and that, that many times we're asking people things and not recognizing the ask. If you've coped with discrimination or assault or trauma by using substances, and we just take out the substance, we've not treated that underlying condition. So when you think of, the level of community involvement that's necessary to treat a substance use disorder, what does that sort of bring to mind for you locally of how many different partners and what types of partners we need at the table to address substance use?
So it's amazing. You talk to one person who refers you to 10 other people to get involved in the community. So I think one of the biggest resources that want to help but don't know exactly what to do are faith-based organizations. So we do a lot with connecting people, and but I hear time and time again, like, our parishioners want to do something, what do we need to do? So I think that's one of the biggest groups. But really, this knows no boundaries and no barriers, that can't be overcome within the community. So I think the biggest thing for all of the community groups is to look for those champions. The ones that are like, I have a son or a daughter, or, I just want to help. What can I do? I think that's the biggest thing. And getting people like this together from different organizations, we don't have all the answers, but I can guarantee you I can find somebody in the state that's going to be able to help you. And making it easy as possible. Some people, like we've talked about over and over, the stigma is so huge, they don't even know where to begin. So the easiest that we can make it for people, the more education and consistent messaging, I think that's one of the huge things that we're making some headway in. But, you have 10 different groups doing the same thing. So if we can all just get together and, incorporate everyone, like I said, it could be your church groups, it could be your elementary schools, it can be your little Rotary clubs, just tons of people that want to get involved in the community, but just aren't sure where to start. So I think that pretty much anybody next to you at any time, you could get involved to help with this effort.
Great. Well, I appreciate all of you for your participation, not only as panelists, but everybody who has been participating. I want to remind everyone that the sessions offer CEUs along with this panel till midnight tonight. So if you need to get those CEUs, make sure that you are participating in the sessions, and then in the details of each session, you'll hit expand, and then there's an evaluation and a a form for you to fill out, for you to complete, and then verify your CEU. And great thank you again to Quality Insights and Marshall and all of the other agencies and committees that work to get those CEUs as part of this. And so there's a wide-ranging opportunity there. I'm so grateful for all of you, and really want to thank all of our expert panelists and speakers who took the time to both pre-record and then join us today. If you have not listened to the speakers, I obviously am biased, as I've had something to do with the behind the scenes work of this, one of many of a wonderful team. But I was truly like blown away by the talks. There are 9 of them. If you take some time and listen to them today and get those CEUs, and if you miss out, they might be housed on the Healthy Connections website following this week. Now, you won't be able to get CEUs for that, but you will be able to participate and hear and then share those. So we would love for you to share the conference even for the rest of today and your participation in it on social media, and make sure you tag Healthy Connections and follow them on Facebook. And we also appreciate any feedback that you have on any of the discussions and sharing them, because I think it's incredibly important to hear about stigma, adolescent treatment, different family dynamics, inclusion of our language, not only to address stigma, but to include all individuals, especially Ari's focus on LGBTQIA. And also, I would have loved to end today, but as always, we have so much information, with a brief moment of mindfulness. But if we did not end today with that, I hope you take a second and go listen to Jake McDonald's presentation on mindfulness. It was a great hour summary that also included 3 brief practices of mindfulness. And so I got to actually sit and do them for a moment, and reminded to do my box breathing this morning. So I hope all of you have the time to do that. So again, thank you very much. Panelists, we ask that you hold for a few seconds at the end. And thank you to all of our attendees. Have a great day.